Hello everyone, this is Mrs. Korea. Welcome to week 5 lecture. This is nursing care of women in labor. This is going to be a very short lecture because most of the content is covered by me during first day of clinical. So I'm not going to repeat every slide here, and you have a detailed PowerPoint for your review. Topics included during this week are assessment of uterine contractions, factors associated with process of labor such as effacement, dilation, fetal lie, fetal attitude, fetal presentations, signs and symptoms of impending labor, assessment of fetus during labor and birth, electronic fetal monitoring, first stage of labor, labor support, and comfort measures. Assessment of uterine contractions. The characteristics are frequency, duration, and intensity. Frequency and duration, please don't confuse yourself. I have explained this very well with the fetal monitoring strip during the first day of clinical. Uterine contractions can be assessed by palpation, which is a non-invasive technique. You apply gentle pressure and keep hand in the same place. And another method is electronic fetal monitoring. Electronic fetal monitoring can be done by external monitoring using a Toko dynamometer, which is a non-invasive technique, and internal monitoring done by internal pressure catheter, which is invasive technique. A little clinical point on using internal monitors. Here you will use a electrode which is attached to the fetal scalp, and we should always remember to remove the electrode carefully after the baby's head is born, because if you don't do it correctly, then there could be a skin breakdown. When you attach it, you usually put it like clockwise, and when you remove it, you have to remove it by anti-clockwise. So if you are trying to pull it and remove it, that can cause skin breakdown on the baby's scalp. So this is a very practical point if you ever see that. Let us discuss about factors associated with process of labor. The passageway is the first one, that is the maternal pelvis and soft tissue. And the passenger, who is the passenger? That is the fetus and fetal membranes. Then another factor is a combined, which is passenger and passageway. Factors come under passageway are effacement, that is shortening and thinning of the cervix, which is expressed as a percentage 0% to 100%. This effacement is also known as taking up of the cervix. And dilation, which is opening and enlargement of cervix, which is expressed in centimeters, usually 1 to 10 centimeters. There are 4 classic types of pelvis: gynecoid, which is a female pelvis; android, which is heart-shaped, and male pelvis. Remember, I told you during the first week of clinical, most posterior positions happens with male pelvis, which is android pelvis. Then another type is anthropoid, the oval brim and a slight narrow pelvic cavity. And another type is platypeloid, which is flat oval shape. Factors under passenger are molding of head, which is overlapping or overriding of cranial bones. And you will see, like after the baby is born, sometimes like a cone head, which is due to the molding. And fetal lie, which is the relationship of long axis of women to long axis of fetus. And there can be longitudinal lie, transverse lie, or oblique lie, which I have showed you again in the first clinical. What is fetal attitude? It is the relationship of fetal body parts to one another, and the normal attitude is flexion. And what is fetal presentations? It refers to the fetal part that enters the pelvic inlet first and leads through the birth canal during labor. And most common fetal presentations are cephalic, breech, and shoulder. And all these terminologies, please remember, they are very important. You should know the definitions. and I have explained this again during the first clinical day. The common cephalic presentations are brow, vertex, face, and military. What are the advantages of cephalic presentation? The head usually largest part of the infant. Remember this. The head circumference is larger than the chest circumference during newborn period. And molding can happen easily when the head is presenting down, and it is the optimal shape, smooth and round, for an easy delivery. What is breech presentation? Here the buttocks enter the maternal pelvis first, and there are three types of breech presentations: frank breech, complete breech, and footling breech. And sacrum is the landmark in breech presentation. There are some disadvantages for breech presentation. They are cord prolapse. Remember I explained this. Presenting part less effective in cervical dilation. Risk of cord compression, which is more dangerous, and you may see variable decelerations in this case. Then risk of prolonged labor. And breech presentation, you still can have vaginal delivery, but many obstetricians or midwives may not be comfortable in having delivering vaginally, and they may opt for doing a C-section. Shoulder presentation. This occurs when the fetus is in transverse lie, and fetus cannot be delivered vaginally unless the rotation occurs in this case. Next is passageway and passenger relationship. First one is engagement. It is said to have occurred when the widest diameter of the fetal presenting part has passed through the pelvic inlet. And next one is station. Station refers to the level of presenting part in relation to the maternal ischial spines. And remember, I have shown this by using the maternal pelvis. So when you call zero station, it is at the level of ischial spines, and above ischial spines it is minus station, and below ischial spines it is plus station. And for example, plus 4 centimeters means that fetal head is at the pelvic outlet. Position refers to the location of a fixed reference point on the fetal presenting part in relation to a specific quadrant of the maternal pelvis. The four landmarks of fetus used in describing position are vertex, here occiput is the landmark, face, chin is the landmark, sacrum in breech, and acromion process in shoulder. And the four quadrants of maternal pelvis are right anterior, left anterior, right posterior, and left posterior. And again, this was shown in my first clinical day. And I want you to refer to the figure 1210 for fetal positions too. So in the landmarks, the abbreviations used, the first and last letter refers to the maternal pelvis. Like in ROA, the R and A refers to the maternal pelvis, and O is referring to the presenting part of the fetus. The middle letter refers to the presenting part of the fetus. Let us discuss about the signs and symptoms of impending labor. The first one is lightening. In lightening, the presenting part settles downward into the pelvic cavity, causing the uterus to move downward as well, and that is called lightening. And the lightening may cause leg cramps, increased pelvic pressure, increased urinary frequency, increased venous stasis, and increased vaginal secretions. Other signs and symptoms include Braxton Hicks contractions. Cervical changes include softens, stretches, and effacement occurs. Then bloody show, which is the expulsion of a blood-tinged mucus plug. Rupture of membranes can happen by spontaneous rupture or by amniotomy. Energy spurt, that is otherwise called nesting. Some women may experience increase in energy. So you may see them running around, doing things, cleaning house, getting ready the baby's room or nursery. So some women experience this increased energy. Then weight loss. GI disturbance include diarrhea, nausea, vomiting, or indigestion. We need to differentiate true labor between false labor. The true labor leads to dilation and effacement of cervix. They will have regular contractions, and the contractions increase in duration, frequency, and intensity. In false labor, there is no cervical changes, and the contractions felt in abdominal region and do not increase in intensity and often stop with inactivity. First stage of labor is from the beginning of signs and symptoms of labor to full dilation of cervix. And the stages of dilation are divided into three phases. Latent phase, that is 0 to 3 centimeters, and active phase 4 to 7 centimeters, and transition phase 8 to 10 centimeters. And I want you to remember this, these phases are very important. And there is something in your book, it is clearly explained. I want you to read that Friedman curve. It's a labor curve assessment tool, and also read those tables from your textbook. The nursing care during first stage of labor include ongoing assessment, facilitate positive birth experience, which is very important. Like some women may say that I didn't have a good experience during my last delivery. So facilitating a positive birth experience is very important. And managing the discomfort, advocate for patients' needs, and provide anticipatory guidance. Labor support include presence, that is physically being present with the woman. You know, someone need to be with the woman, the labor support person. Sometimes they may hire a doula, and the nurse. You know, like if we really go away for a long time from the patient, they may get anxious. So physically being present with the woman is very important. And spirituality, prayer, meditation, chanting, etc. Some women prefer to do that, so we need to honor them. Comfort, position changes, personal comfort measures. Some people may use the big balls to sit on them, lie on them, or lean on them. Then the environment. Some women may prefer lights dimmed, some women may prefer light streaming into the room, so we just honor their wish. Personal hygiene need to be maintained. Elimination, empty bladder. Encourage them to empty bladder, assist them to walk to the bathroom. And in the olden days, it is not just a bladder, the bowel elimination also was recommended, but with an enema, but it is no longer recommended. And we also gave supportive relaxation techniques as per their wish. Fetal assessment include assessment of the position, fetal heart sounds, checking the baseline fetal heart rate, presence of variability, accelerations and decelerations. Please, I want you to listen to the video and learn how to monitor fetal heart rate carefully, and if there are possible questions from there, remember that. Interpretation of fetal heart rate patterns. The goal is to assess adequacy of fetal oxygenation during labor and consider contraction frequency, intensity and stage of labor and earlier FHR patterns. Understanding of FHR physiology and influences on fetal heart rate is essential. Use NICHD nomenclature system for electronic fetal monitoring interpretations like categories. That category 1, 2, 3, which is explained in box 12.7 from your book. Nursing care includes monitoring for fetal heart rate decelerations. In early decelerations, you don't take any actions. In variable and late decelerations, position change, oxygen per mask, vaginal examination to see if there is any cord prolapse, palpation for tachysystole, discontinue oxytocin, and correct maternal hypotension.